Batul has already shared the title of the talk, Designing with People, Systems and Data in Health, which shares our design-led approach to frame and sense-make and better understand health and care systems for MLTC, multiple long-term conditions, or what the more kind of clinical term being used for is multimorbidity. And during the talk, we share some of our overall approaches and specifically introduce the person journey and system maps model. I'm Farnaz Nikpour. I'm a reader in inclusive design and human-centered innovation at the School of Engineering, University of Liverpool. I'm director of the Inclusionaries Lab for Advanced Design Research based in the UK, and I'm also a theme co-lead at Civic Health Innovation Labs focused on health systems. I'm trained as and educated as a designer, industrial designer, and design for strategy and innovation. And the majority of my work focuses on developing and applying design methodologies, practices, and mindsets, mainly in the context of health and mobility. In this talk, I'm joined by two of my highly valued colleagues. They are ECR, early career researchers from the Inclusionaries Lab, Isabel Leeson and Fazil Akin. They will introduce themselves when they will start talking. So with that in mind, I will just give you a quick overview of the talk. I'm aware that the topic of design and design applications might not necessarily be a core topic for many of people who attend the talk. So we start with an introduction into design in health. We call it Design Meets Health, and we share some of our critical observations and suggestions for how we think design should be better applied in the context of health, considering the potential value and impact it could have. We then introduce a design code. This is something that we are making an argument for the existence and application of a design code in all health projects. We then focus mainly on the systematic project. We talk about the overall health and care systems for MLTC. We talk about the application of the design code in systematic projects and the processes we use. And then we share the three-tier person journey and system map model for systematic. And we finish with reflections and way forward. So I will start with design meeting health. We're very interested in taking a kind of step back and looking at the wider applications of design. We are very well aware of the increasing interest in an application of design in health. And if I want to start by talking about the kind of contributions and interventions level, this model might be quite helpful, which talks about 4 orders of design. And this might be 4 orders of design in any field. The examples that we have shared here are specifically around design in health. But typically, when we talk about design interventions, we talk about 4 orders of interventions, starting with the first order. And as we move to the 4th order, from first to 4th, we have increasing complexity. So we start with visuals. We talk about applications of, outputs as communication and graphics, for example, a project focusing on reducing aggression in A&E, where the main output, rather than redesigning the furniture or redesigning the service, was actually providing actionable, clear, and timely and live information with people through graphics. The second order of design interventions and applications is products. So we talk about design of objects and artifacts. The example provided is called Elevix projects, where our Inclusionaries Lab is the leading design partner in designing an upper body exoskeleton for children and young people living with progressive neuromuscular conditions, specifically DMD and SMA. We move to the third order, where we talk about designing interactions. So we talk about design and design of services and experiences. And then we move to finally to the most complex level of interventions, such as systems. So as you can see, we move from tangible artifacts to intangible transformations. And something that needs to be considered, as the visual recommends, is that every top order incorporates the lower orders within it. So every system would have an interaction, a service touch point, a product touch point, and a visual touch point, and as we see. So if we move to why, so it's useful to actually look into why design is being considered relevant and what is the potential value and impact that design could have in health. Thinking about solutions, design has got inherent human-centered and inclusive approaches that offers an innovative approach in terms of solutions. So we're talking about helping shape people-centered care solutions that are intuitive, inclusive, and aligned with the needs of both patients and clinicians and commissioners as well, using inherent generative and participatory approaches. But beyond that, not necessarily looking at interventions and solutions, design has got some framing capacities in terms of tackling what we call wicked problems, problems which are complex, which are highly interconnected, and it's not necessarily by fixing one, you cannot solve the others. And here, what design offers is more around fostering partnerships and collaborations and providing approaches which in the first place help unpack and better understand complexity, interconnections, and generate some ideas which potentially could be transformative. Another aspect that we are very interested in when we apply design in health specifically is combining and connecting what we call big data and thick data and helping sense make that. This is really about connecting complex data with rich real-world qualitative stories of people who actually experience the product, service, or system, and making these insights understandable and actionable for patients, providers, and policymakers. You might notice we have provided some references to in the slides and some QR codes as we go ahead. So for example, this one is a publication of our own which looks at opportunity for inclusive and human-centered design, published in British Dental Journal. Now, I'm aware that we've talked a little bit about design, but I haven't really provided a definition of design. Increasingly, when we work with non-designers and colleagues from other fields, we've learned that it's extremely important to define design at the outset. And we define design on 3 orders. Again, if you think of it as an iceberg model, most people would actually be familiar with ontological aspects of design, i.e. design contributions and outcomes, or praxeology of design, where we talk about design processes and tools. But actually, we argue that it's very important that you define design as epistemology as well. These are the parts of the iceberg which are hidden, but actually really impact design processes and tools and design contributions and outcomes. And by epistemology, we're mainly looking at design principles, design mindsets, knowledge sets, methodology sets, and skill sets. Something that's also important to mention in terms of what you see on the surface of design is to acknowledge that design and applying design processes doesn't only end up with interventional contributions. And as you can see, the interventional contributions are divided into systems, interactions, products, and graphics, as we talked about. But design could also offer conceptual, methodological, and empirical contributions. So now that I have provided some basic definitions of design, and I would really invite you to consider a more epistemological and a kind of a knowledge-based and methodology-based approaches and definitions of design. We want to share some critical observations and suggestions for transitioning design in health. These are based both on some reviews of design and our own experiences in design. So the first one is a review of the state of the art of design in health, published in 2015. And the third, and the rest of them are reviews, systematic mapping reviews, which are conducted in our inclusionaries lab, which look at quite diverse aspects or fields within design and health. For example, oral health, pediatric mobility design, and palliative and end-of-life care, where we decided to take a kind of step back and look at the wider picture or landscape of design presence and applications. And if you move to the next slide, you will see that interestingly, there are some common observations in terms of critique of current applications of design, and then where we suggest some potential transitioning. We are sharing this with everyone in the team because we are hoping that there would be potentially some applications or collaborations with designers at the moment within the projects that you do, or in the future, and we think it might be useful to share these. So I'm going to start with the core aspect, which is design epistemology, i.e. design knowledge and methodologies, design theories. What we observe at the moment is what we call superficial adoption. So current adoption of design is quite tokenistic and without understanding of the deeper an application of the deeper principles, theories, and methodologies. For example, when we were looking at the systematic mapping review of design in oral health, we came across a paper, and this was a really extreme case, but you see many cases like this where in the title of the paper, there was a mention of user-centered design, but nowhere else in the title there was any mention whatsoever of UCD or, like user-centered design. Again, looking at that kind of tokenistic approach of, okay, design seems to be trendy. The other aspect is design being viewed as a supplementary tool. I've been approached multiple times by potential collaborators. It's like, we have got a little, budget left and we would like to do something around design. So design is typically viewed as an add-on rather than a foundational approach to derive health and health research and innovation. And what we argue for is that we really need to look at design as a potential core strategy alongside other disciplinary strategies. The other aspect around current application, looking at the systematic mapping reviews and our own experiences, is the focus on user-centered design approaches. These are extremely popular, which is fantastic. But then, interestingly, that kind of wider systemic and contextual views and integration of those theories and practices is not present. If you look at the design processes and tools, so look at design praxeology, we see a very common phenomenon which we call design without designers. And this is really about lack of embedded design expertise and, more importantly, leadership in health teams. So and I think part of it is the fault of us as designers, but also the view that non-design community, in this case, health partners, have of design, that it's quite easy to look at, like attend a crash course or a quick kind of like boot camp on design, be introduced to design methods, which is the kind of like superficial or surface level, and think that we can go away and design and apply those methods ourselves. Another aspect, which is very related to this, is this kind of over-reliance and oversell of methods and tools, and specifically kind of certain methods and tools such as co-design, which we understand at the moment is very common and very applied. But this really introduces a major danger, which is adoption and application of more potentially relevant approaches and broader design practices in your project. The next issue is really this formulaic approach, the kind of rigid and tick box practices and stage-based processes, rather than adopting in more of a kind of iterative and creative and adaptive approach to shaping your design strategy. And the next point is looking at problem solving, specifically, rather than looking at the wider the process of both framing and solving, which leads to ill-defined and sometimes narrow problem definition. If you look at the top level, which is the kind of design ontology in terms of design contributions and outcomes, this is the dimension that is most visible. Here we're looking at some localized interventions which do not have any pathway for scalability. So solutions are often quite limited in scope and impact. And if you think about the different types of interventions, we talk about graphic, product, service, and system. These interventions based on our systematic mapping reviews are typically focused on product and service levels, and systems and policy related interventions at the moment are not present as much. The other aspect is focusing on interventional contributions and forgetting about the other three types of design contributions, which could help strengthen a project, i.e. theoretical, methodological, and empirical contributions. And the last point here, which I think may or may not be relevant to many colleagues and attendings in this call, is focus on health tech rather than adopting a wider socio-technical approach. And what I mean here is this overemphasis on technology as the solution rather than enabler. So we are talking about tech-centered rather than tech-enabled approaches, and forgetting that technology, at the end of the day, is fantastic and it could help save lives, but it needs to be designed to fit the user and the context of use. So with this in mind, I'm going to very quickly introduce the design code. And what is a design code, and why are we keen on, for every project, introducing and building and shaping a design code? First of all, based on what I have said so far, we are very keen on avoiding a limited design approach. And what I mean by limited is this more kind of tokenistic, myopic, and sometimes off-the-shelf and selective approach to, okay, co-design seems interesting and relevant, let's adopt co-design, rather than, well, let's work with a designer and a set of design experts to see what are the relevant set of design principles and practices and methodologies to our project. And the second point, beyond having kind of avoiding a limited design approach, is to actually be able to offer an advanced design approach. And by that, we mean an approach that is holistic and integrated, is adaptive and combinatory. So potentially allows more of a generalist specialist design approach beyond just focusing on one practice or discipline of design, is iterative, creative, and strategic. And what we argue is that every health improvement, innovation, transition project which has got an end user facing aspect should be informed by advanced design theory and practice. And we define this design theory and practice as a living and a learning unique set of design principles, practices, and outputs, which is, again, you have come across that when we talked about a design definition, and we call this a design code. As you can see, the design code has got three key parts. First of all, again, this is the invisible but significant and core part of a design code, which is design principles, mindsets, and methodologies. And I'm not going to go through what we consider as the meta code in a design code. This is present in every design project that you apply. Then we move on to the next part, which is design practices, which is the set of processes and tools that we use in design. And what we consider here in terms of experimental, iterative, the use of modeling, visualizing, and prototyping to sense make and solve, and then the embedded participatory approach in design is a core part of the meta code. And on the third level, we talk about outputs, which are including the outcomes and contributions, and as I mentioned, have considered all the four aspects beyond interventional, also methodological, conceptual, and empirical. This is what we refer to as the meta code, which is present in every design project. But then going forward, you build, working with designers, your own unique living and learning project design code, building on that and expanding on that, which we will explain a bit later. Here I hand over to Isabel to take you through the systematic project and the methods, methodologies, and the models that we generated for this project.
Hi everyone, as Farnaz mentioned, I'm Isabel Leeson. I'm a design researcher, member of the Inclusionaries Lab, and I've been research associate on the Systematic project. So Systematic is a collaboration between the University of Liverpool and the University of Glasgow, and it focuses on prevention, precision, and equity by design for people living with multiple long-term conditions. It was seed funded by NIHR and EPSRC as part of the SEISMIC scheme, which gave us a sort of 18-month development period for discovery and development work to set up an innovation hub around multiple long-term conditions. So that development phase ran from mid-2023 to January 2025. So we're submitting our grant application for the full hub this week. And we have a digital commons where we share resources and outputs from the project. There's a QR code in the corner, and in some places later in the presentation, we've put a few links on it, so you could visit them for more information about some of the slides. So we know that MLTCs are a growing challenge, and they have a significant impact on individuals and health systems. And we also know that they affect disadvantaged communities earlier and with more significant impacts. And this is really relevant in Liverpool and Glasgow, where there's high levels of deprivation and multiple long-term conditions. So that's really the focus of systematic. And at the same time, we have rapid development and growth of technological solutions, but they're often quite siloed technologies for health that fail to integrate across conditions and often can exacerbate inequalities for sort of excluded groups. So the sort of aim objectives of this development phase of systematic was to develop a holistic and shared understanding of the current state of the health and care system for people with multiple long-term conditions, and identify priority areas and key points for systems change. And so the final outcome, as I mentioned, is a plan for the systematic hub, which aims to equitably transform multiple long-term condition prevention and care in Liverpool and Glasgow. So going back to something that Farnaz was mentioning, this is all about framing. So a typical sort of representation of a design process is this double diamond, where the left diamond is about framing or designing the right things, and the right-hand side is about solving or designing things right. And this development phase of systematic is all about understanding and framing the problem. So framing and design is split up into two stages. So the first is discover, and that's around engaging diverse stakeholders and building a deep understanding of the system. And this is a sort of divergent process where lots of issues are unpacked. And then the second phase is around define, which is a convergent process. So it's synthesizing all of those perspectives to come to a well-defined focus. And at that point, you would then decide how to act or how to start problem solving. So in systematic, the approach is sort of built on this structure of 3 working groups studying people, data, and systems. And these groups work independently to understand the system in detail from their own sort of distinct points of view before coming together to synthesize and strategize and bring all of those perspectives together. So you can see that this diagram shows the development phase design process for systematic, and we had 5 stages during the development phase. In stage 1, those 3 working groups were working independently to understand and frame the problem on their own before we then came together in a series of workshops to co-define and co-prioritize problems and develop the strategy for systematic going forwards. And what we're going to talk to you a bit more about today is mostly around the people insights work in Liverpool. So that includes this process of first discovery and deep understanding from multiple stakeholders, and then coming together with the other working groups so the health intelligence and systems science groups in Liverpool, as well as bringing on board various system stakeholders to co-define and co-prioritise the problems. So this slide gives a sort of overview of the process that we went to and the methods that we use. We're going to go through these and pick out some key bits to highlight and tell you more about today. So if we first look at data collection, what we wanted to do was to gather perspectives from both people with lived experience and a variety of system stakeholders, so including health and social care, voluntary community, faith, social and enterprise organisations, and understand their perspectives on the current state of health and care systems for people with multiple long-term conditions. And we selected a set of methods to do this, and these are intended to be inclusive and creative and flexible. So for our lived experience participants, we offered a choice from activity books, which were filled in at home in their own time. We had one-on-one interviews, and we have focus groups. And they could choose to do any combination of these, so they might do one or all three. And we developed and tested those materials with our public advisors first, and then we validated any findings from them. We took them back to the participants in a workshop to validate any insights and findings from those. So on the right hand side, you can see some snippets from the activity books and different activities that we did with them. I'm now going to hand over to Fazil so he can tell you a bit about the sort of data analysis and synthesis stage.
Thank you, Isabel. Hi, I'm Fazil. I'm a lecturer in industrial and product design at the University of Liverpool. I'm also a member of the Inclusionaries Lab. I have a background in industrial design, design management, and designing for experiences. And my research fields are also aligned with designing for experiences and philosophy of technology, human technology relations. So I will be going through to the data analysis and synthesis part of the systematic project. First, we applied a three-level, three-tier system person and journey semantic zoom. To really understand the system, we need to really understand the person first and really capture the journey of the person. And then we can really map the system and all the actors and the relation between the system. So we will have three different levels of zooms: macro, meso, and micro level zooms. Next slide, please. So for looking to the person, we should understand the context of the person and how the person living with the multiple long conditions really have different needs, goals, and different patienthoods. And for this, we were using the person maps. And for the journey level, we were looking to the person's journey with the system, with the health and care system, and also really with all the challenges of the daily life, so all the interactions, pressures, and relations. After that, we were able to understand the system and really map all the relations and flows in the system. For that, we were using the system map and the actor maps in our model. Next slide, please. So when we were looking to the person, a very common tool is the personas, but we were looking at it in a very critical way that sometimes they could be stereotyping and they may also create biases. And it was not enough detail for us to really understand the person just through building personas. So as you can see, we will have all the maps also linked in our digital common, and we will give some brief information about all of these, but there are some more information in the digital common, and there is also the templates to really look how we developed them. And we were looking to the person as in three different levels: the person and their context, their health condition, and their patienthood towards the health and care system, and to technological or technical technologies, different technologies. And we were also developing these tools with people lived experiences, and also with healthcare providers and people from VCFC sectors. And it was for us quite important to really understand the person, but really also understand the dimensions that, because a single person will have different types of features. And when we look to a wider range of people, we will have then dimensions of the person. And we were also developing in the corner, you can see the wheel, which we are calling it the dimension wheel of the person map. From the person, we will need to go to the next level, which is the journey, and how the person is really interacting with the system. And it could be it could really based on a timeline. And in our project, we also saw that the medical system really treats conditions separately, but the person really experiences all the conditions all together. So it was not really the most human-centered approach to really separating the symptoms, but as the journey is really all about the combination of the journeys, just the systems. And it is also quite important for the project, and Isabel will explain further details of the journey map.
Thanks, Fazil. So I'll just give you a quick overview of how we went about modelling and mapping journeys of multiple long-term conditions. So this is quite not a straightforward journey, because you have multiple conditions and they're not necessarily linear journeys. But this is our starting point, which is from another research project. And this is their model for a single long-term condition, which they say they basically understand by a linear part, which is around getting a diagnosis and initial treatment, and then a circular part, which is around living with the condition long-term. So when we thought about how does this translate to multiple health conditions, as Fazil mentioned, people are experiencing these multiple conditions concurrently. So we didn't want them to be 4 separate linear and circle parts, for example, because we know that when people are living with them, they're living with them all together. So this is our sort of basic adaptation of the model. But of course, we knew that, and we knew through working with our public advisors and participants, that the reality is a lot messier. So journeys often aren't linear. Some journeys might be more significant than others for specific conditions. The journeys of different conditions interact with each other, and the stages sometimes happen in a different order or don't happen at all. And we know that in that circular part of the journey, different conditions might go around that loop or fluctuate much more than others. And alongside the sort of piece from the circular part of the model around managing symptoms, there are a lot more burdens that a person is managing, which relate to having multiple conditions, such as managing appointments or prescriptions or other things. So to talk a bit more about these journeys with people, we developed this model or template, and it has expanded slightly further on that previous model. So we have the stages of before conditions, that same linear part of initial symptoms and diagnosis and early care. Then we have the circular part of living with symptoms, and then that additional stage around all the additional burdens of living with MLTC. And then it goes to end of life care. So we use that template as a way to explore with people what was happening in each part of their journeys, and where the significant moments were, where significant pain points or interactions were, where there might be opportunities for improvement or systems change. I'll hand back to Fazil to talk more about the systems mapping now.
Thank you, Isabel. After understanding the person and their context and really mapping their journey with the system, the third point is really looking into the system. And the system map is really a tool to visualize the complexity and also identify points to change in the system. When we were looking into the literature of systems thinking, there were three different ways of looking into the system. And one was like describing the system. Some other literature were really trying to predict. And the third way of approaching systems is how we really change it into a better one. So we are adapting the change, approach. And one of the core literature that we were finding very useful was Meadows' leverage points for system change, where the parameters are easier to change, but they will have less effect to the whole system, and where the mental model is most effective, but then they are quite difficult to change. And also we were looking in three orders of system level change, and optimizing and innovating and transition of the system could be a way of how we can change the system. So these were the two frameworks we were using in our own system map model. Next slide, please. To really make it into a more basic way of dealing with the system change, we were differentiating in 4 levels, assets and parameters for the health system. They could be staffing levels, duration of the appointments, or the budgets. They would be the assets and the parameters. And in the second level, the relationships were the points, like referrals and personal relationships. In the third part, structural organizational parameters would be where the system could be optimized or in transit. In the fourth level were the mindsets, the system goal and the attitudes. So we developed this tool also with people living with MLTCs and also with health professionals. And the tool was also used once also to gather insights from them and also really identify points how we can really intervene into the system. So the final map the final version of the map is on the right side. And we were also using a field one for our stage 2 workshops to really understand or propose at which points it could be that we can intervene into the system. As you can see, all the points that we identified, although they are in different, they are in different categories, they are all really connected. Next slide, please. So after understanding the person journey and and the system, or having some insights about them, it was the time really combining our insight with the health intelligence group's insights. So we conducted workshops where all researchers and also people from health care and people with living MLTCs came together and really discussed which points and which problems were in the system that we can intervene. Also, we developed an interactive report, so people who were not able to join the workshops were able to give their opinions about it. After putting all together these problems, we also developed an interactive system problem definition map, which is on Kumo.io, and you can have access to it using the QR codes. And it would be also great if you can also contribute, because this is a really living interactive map where we really gather insights and also we make sense of them. So you can really contribute to that mapping as well. So we identified that the problems could be categorized into 3 levels: people and place, system design, and MLTC approach. And yes, next slide, please. After identifying problems, I think it is quite a crucial way of dealing with issues as a designer, that you would like to really propose some solutions and propose how to really overcome some of the challenges. So we put them into this graph where we identified where to intervene and in which level to intervene. So is it an optimization, or is it like an innovation, or is it a transition level? So it is not singular projects. It is really important that there is a combination of points to intervene. It's not singular points. It's a portfolio of points to really try to change. So I will hand over to Isabel back.
Thank you. So we just wanted to share some final reflections on our contributions of our design approach within systematic, and what sort of works well and was valued by ourselves. And we had good feedback from health partners, and then we'll share some other challenges as well. So the first is going back to this idea of this living and learning design code, and we think this is really critical in design work in health, starting on that principles and mindsets level and working with designers throughout. So this is a sort of working version of our systematic design code, but I think on that principles level, that human-centered and systemic approach was really important throughout systematic, as well as our sort of practices of modeling and visualizing. A lot of our models and templates were really helpful for talking through problems of different stakeholders and understanding the problems. So I'll hand over to Farnaz now for some more reflections.
I think Fazil will start with the tool contributions and outputs.
We were identifying things that were very well defined or very well appropriated from our stakeholders. Some of them are on this list. So bringing really the qualitative data with the quantitative data was one of the points, and it is very solution oriented. So designers are really keen on solving problems, not just identifying things. So most of our outcomes were actionable, and all the tools, they were really designed specifically for the project, so they were not tools that were already there. I think this is also a way that a design group is really approaching such a project. I think transdisciplinary, participatory, and non-hierarchical and iterative features of design were also quite visible, and really understanding the extremes and the mainstreams. It's not really, there was also another point that we really tried to get insight from all different parts of the users of the system, and also having not just one solution for as an outcome, and rather having a portfolio of solutions was also identified as a point from a designer's perspective.
I appreciate we are throwing quite a lot of information at participants. This was quite an extensive, especially the discovery stage of the project, design-led project. So there are aspects that we haven't been able to share with you, but we are mentioning them because we firmly believe in kind of collaborative working in the future. So if there would be participants or colleagues who would be interested, of course, we'll be able to share more about that or continue conversations. One of them is the iCare framework, which is a framework that applies design-led methodologies to both advance and disentangle PPIE. This would be the topic of another full, I would say, talk, which by PPIE, we of course talking about patient and public involvement and engagement, but looking from a human-centered and inclusive point of view, we have some arguments around how we need to disentangle the patient and the public, and how we could potentially not only disentangle, but advance kind of methodologies, approaches, tools, and practices for patient and public involvement. In the iCare framework, we look at application of inclusive, creative, accessible, responsible and equitable participant engagement in health and care improvement. This is a framework that we have been working on iteratively on a number of projects at the Inclusionist Lab, including not only systematic, but also ELEVIX project, which is looking at design of an upper body exoskeleton suit. And this is a framework that we're constantly kind of working on. So it's another living framework. But two last, but I would perhaps say most important points or reflections or things that we might kind of invite the participants to take away with them is the multi-tier person journey and system model. We look at this model in two capacities. We firstly look at it as a holistic model, which looks on different levels and orders. So we talk about the semantic zoom, like for framing complex health systems and integrative thinking, looking at the person, following their journeys and contextualizing the person and their journey within the system allowed us to bring isolated and compartmentalized views, actors, and orders, and sometimes competing constraints from different project partners together and build a rather inclusive and holistic and kind of convergent model around what is the problem. But we also, beyond the kind of framing capacity, we look at it as a tool to discover, to inform, discover, and define stages of the design process, but also as a tool to steer in the next stages, hopefully, if you're successful in taking the project forward and moving beyond the discovery stage, the information and kind of insight that we have gathered on the person, journey, and system map, and the models and templates that we have developed would be very helpful in steering the development and delivery stages of the design process. Next point is really looking at design. So you have not heard anything from us about designing an initiative, a product, or a service, or a graphic. We have mainly talked about design in its sense-making and framing capacities as a kind of generative contributor. And here, really, we're arguing for use of design synthesis as a method or an approach that attempts to interpret and make meaning out of data and make this meaning explicit through various forms of externalization, modeling, and visualization. Therefore, it facilitates more tangible, collaborative, and external sense-making that is action-oriented. I would say the strongest part, which was appreciated by our non-design partners, was this aspect that when we were sharing our iterative models of journey maps and system maps, multiple partners, either from the kind of lived experience or disciplinary expertise, were finding it really helpful. It's like, oh, this is what I have been dealing with, this is what I have been experiencing, or this is what I have been suffering from as a provider or end user or policymaker, but I haven't been able to make it tangible, external, and kind of communicate it with others. I will quickly move to our challenges. Of course, every project has got its own challenges and limitations. And I would say we really found it more challenging. While we were quite successful in design-led aspects of the project around discovery and framing, we found it challenging when we moved to shared and collaborative problem prioritization and definition. And this was mainly due to multiple aspects, for example, power dynamics or disciplinary mindsets and hierarchies at play. So the leadership and the decision-making at the point where we are actually deciding which projects we want to focus on, which problems we want to prioritize, and which projects we want to define is far from transdisciplinary. The other aspect that we observed was that as we moved on to kind of defining the problems, that systemic view that acknowledges complexity and is more comfortable with remaining with the kind of like ambiguity was kind of getting slightly weaker as the interdisciplinary partners move into kind of health initiative decision making. And again, the kind of the disciplinary perspectives come in quite strong. And the other aspect, which is quite related to the other two, is kind of embedding and buying into design mindsets as we move from design discovery into and design-led activities onto kind of like focusing on delivery of the project. I appreciate that we have hardly left any time for Q&A. Our apologies. I hope that the participants would consider this as a sign of our enthusiasm and the kind of like the extent of content that we wanted to share. We have provided our email addresses and, more importantly, QR codes for the Inclusionaries Lab, where we can read a little bit more about the range of design and health and mobility projects and approaches that we adopt. A link to Civic Health Innovation Labs, which is leading the systematic project, and a link to Systematic Digital Commons, which is actually inspired and informed by what we consider quite useful structure and approach in Turing Commons. So thank you so much, and I appreciate there is very limited time available, but